بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. Today we have communication 1 or communication with person or relative. This will be done by Dr. Mo Rida, Muhammad Rida. Dr. Mo is working in UK and he's the most expert one to discuss with you in communication. Even I have the updated, and Dr. Muhammad also he has updated as he's the one who's doing any edition or any extra edition for the book. So he's very familiar and aware about all the updates. But the most important point is that he's working with them in UK. So he also, I think he's taking courses in communication in lab. So he will be very close what they are asking in communication. So please today, one of the most important discussion in our course. Why? As communication skills in the exam, not only these 20 marks. I told you in previous lecture, it was 60 marks. So communication will be in all stations, examination, procedure, history. And all will be built or will be depending mainly on this discussion for today. So please, today is one of the most important lectures in our course, as you have about 60 marks in your exam from this lecture. Okay, Dr. Muhammad, you can start.
Thank you. Thank you for the nice introduction. My name is Dr. Mohammed, or Mo, as most people call me. I've been working in the UK now. This is my third year. I'm working in orthopedics as a trauma fellow. I passed my Mrcs back in 2019. And today we're going to talk about communication skills, right? So in the exam, you will have two communication stations, okay? One of them is communication with a person or a relative, and the other is communication as a phone call. And Dr. Salah has already given the communication lecture about the phone call. All right, let me just get my pen ready. So communication, you have two stations. One of them is relative or a patient, and the other station is going to be a phone call. Okay. Both stations are 9 minutes, like every other station in MRCS, so 9 minutes. The difference here is you don't have a bell. Like for example, in the history station, you have a 6-minute bell. So the bell goes off after 6 minutes, and then you have 3 minutes to discuss with the examiner. But in communication, you don't have the 6-minute bell. So you spend the whole 9 minutes either talking to the relative or the patient, or either talking to someone on a phone call, all right? So some very important things to know. So when you go into the relative or the patient station, you will find 3 people. Obviously now, because of COVID, that might change, and you might have just 1 person or 2 people rather than 3 people. And we're really not sure how it's going to be done because of COVID restrictions. So there might not be 3 people, but the normal way or pre-COVID, there used to be 3 people in the station, okay? One of them is the relative or the patient. So that's an actor, all right? So that's number 1. Number 2 will be your examiner. And number 3 is going to be a lay examiner. And what does that mean? So the lay examiner, his purpose is to assess how well you're using simple terms, if you're using layman's terms. So this is what we call layman's terms or simple terms. And he assesses you to make sure that you're using simple language so the patient can understand you. So you're not allowed to use any medical jargon or any medical terms because the patient or the relative is not going to understand the medical terms. And this is very important while speaking to a relative or a patient. You have to use simple language. You have to explain everything to them in detail because they might not have a medical background and they might not understand what you're trying to tell them. So you have to use simple terms, all right? So like every other station, it's 20 marks, 20 marks, okay? The examiner will assess your medical knowledge, and he will also assess your consultation with the patient, while the lay examiner will assess your rapport with the patient. If you develop good rapport with the patient, he will assess your layman's terms or simple language. He will assess your body language and how will you use empathy towards the patient. Okay, examiner has 15 marks and the lay examiner will give you 5 marks, so that's a total of 20 marks. All right. While in the phone call station, and I'm sure Dr. Salah has already explained to you, you will be speaking to a colleague, usually a senior colleague, or for example, a consultant, or maybe ITU registrar, as in someone senior, and you're usually trying to refer a patient or ask for advice. The point here is if you're speaking to a senior colleague, you are allowed to use medical terms because you're speaking to a professional with a medical background. So here you can use medical terms, it's fine. But in this station with the relative or the patient, you're not allowed to use any medical terms and you should just use simple terms or simple English. All right? Is it clear so far? Good. So 2 stations in communication. Before you enter the communication station, you have something that we call a prep station, preparatory station. And I'm sure Dr. Salah has already told you in the phone call station, but before any communication station, you have a preparatory station. Okay, so before you go into this station, you have a prep station. Before you go into this station, you also have a prep station. So what is this preparatory station? So the preparatory station is also 9 minutes. Okay, it's also 9 minutes. But in the prep station, there's no one in the station. You go into the station and there's no one. There's no examiner, there's no actor, there's no lay examiner, there's no one. You go in, it's an empty station, but what you have inside is a set of notes. So you have patient's notes, okay? And I'll show you an example in a moment. Once we get to that station, I'll show you an example of a prep station and an example of the notes that you will find inside. So before you go in, okay, you will have a piece of paper on the door. Obviously, like any other station, it will tell you the scenario, and then you go in, you will find a set of notes, and then you can read those notes, okay, and just find out what's happening. So sometimes you will find history from an FY1 or a foundation year doctor. You will find someone has entered, for example, an ITU referral or whatever. So you'll find the patient's notes, read them. You'll also find some blood tests inside, all that stuff. You can make notes of your own because when you go in, you'll have a piece of paper and you'll have also a pen or a pencil. So you can write down some notes. You can write down the important blood tests and you can keep that piece of paper. You can keep it with you. So when you go to the consultation or when you go into the phone call station, you'll have that piece of paper with you. Okay. Personally, I don't recommend taking any notes, but obviously it is up to you. You will have pen and paper if you want to, but I want to stress that it's really important when you go into the relative or the patient station, that you make eye contact and you pay attention to the patient and not look at your notes or not look at the piece of paper that you have, because that is not good communication skills. And that's why I don't really like taking notes, and I don't really like looking at my notes while I'm discussing or while I'm having a chat with the patient, because it's not really good communication skills. You should be paying attention to the patient or the relative, and you should be making eye contact. And it's not always a good idea to keep looking at your piece of paper, but it is there, and you can take notes if you want to. I think it's really easy to remember, but you have that option, all right? And again, I'll show you an example in a moment. All right. Before we start our first station, I would like to tell you some very important stuff in communication skills. It's really, really, really important to make eye contact, okay? So whenever you're speaking to a relative or patient, make sure you maintain eye contact, okay? And that's something that we might not be familiar with in our culture. We tend to look away or look down, especially if it's a stressing moment, or especially in stressful situations, you might look away. But it's really important to maintain eye contact throughout your consultation or throughout the chat that you have with the patient, right? Number two, we said this before, but it's very important to use layman's terms, okay? You will lose marks if you use complicated English, complicated medical terms. Examples, for example, is esophagus. You can't say esophagus. You can say food pipe instead, okay? Trachea, you can say windpipe, okay? Instead of abdomen, you can say tummy, okay? And so on and so on. If you want to ask about a urinary tract infection, instead of saying urinary tract infection, you can say waterworks infection, okay? Or any problems with the waterworks, and so on. And we will go through some of these terms, but if you say complicated medical terms, the patient or the relative will show you that he's confused. They will ask you, what do you mean by a urinary tract infection? I don't really understand what you mean, and you have to explain to them, all right? The third most important thing is body language, okay? And that includes simple nodding, your hand movements, the way you use your body. Basically, don't sit still, or don't put your hands on your lap or your thighs and talk in a monotone voice or talk in a robot voice. You have to show some interaction. You have to be basically paying attention to what the patient says, nodding, showing some empathy, and so on. All right. Number four, give the person, or basically give the actor or the patient a chance to speak, okay? Communication is different from other stations. For example, in history, you try to get the most information out of the patient as well, as fast as possible, really, because you only have 6 minutes and you're trying to gather as much information as you can. So sometimes you might interrupt the patient if the patient is talking something irrelevant, and you might ask him another question just to speed things up. But here in communication, it's really different. You have to give the person in front of you a chance to speak. Do not interrupt them. So do not interrupt, okay? You might think that you're losing time, but actually you are gaining points. As long as you give the person in front of you a chance to speak, a chance to voice their concerns, the examiner will be very happy with you. You need to nod, you need to show that you're listening, you need to show some empathy. If the patient says something sad, you need to show that you're sorry, that you're feeling sad as well, and so on, and just let them speak. And after they're done speaking, you can address their concerns, okay? Number five is going to be empathy, all right? So again, if the person that you're speaking to says, my father has died from cancer, or my father died from a heart attack, or my sister had an accident, or whatever, you need to show that you're sorry. You can say, oh, I'm very sorry to hear that, or oh, that must be very difficult for you, and so on. Just show some empathy, show that you care, even if you don't. He's an actor and you're acting as well, but that's how it is, and that's how you will pass the exam. You're showing that you're sorry, you're showing that you're paying attention, you're showing that you're a caring doctor, and don't just move on to the next question. If they say something sad, then you need to show empathy. You need to tell them that you're sorry. Okay, good. If everything is clear, we can move on to our first station.
Okay, give me chance, Dr. Muhammad. Thank you. Hello.
Yep, go ahead, Dr.
Okay.
Salah.
All the points now shared by Dr. Muhammad is very, very important. I will tell you some things happened. You will find in one station now angry patient. I will give you experience for this station, and all our candidates, especially in Cairo Center, started to crying. Why? Why this happened for us? They have a very good actor. She is Egyptian, female, angry. She is shouting, and this is what will happen in your exam. By the way, this is her rule, and examiner is looking for you to see your reactions. Okay, if you will find the patient is shouting, every word you are telling, shouting, shouting, shouting. This is how Dr. Muhammad told you to be calm. يعني shouting, يعني she is shouting, even you are explaining everything from our course exactly. Why she is shouting, still shouting? Shouting because this is her rule. They want to see you. How is your reaction after this? Okay, this first point. Second point, for apologize for any mistake. Before, when we are doing practice, we are telling for any mistake or like cancel operation like this way, you should tell, I am so sorry for that. I am so sorry for that. Don't repeat it more and more. Examiner told frankly, if you will tell again, I am sorry, you will be out of the station. He told that frankly. So you will apologize, but not for every sentence. You will tell, I'm so sorry for that. I'm so sorry for that. Others, like Dr. Muhammad said, layman language is very important to use simple terms. Now you will find it's difficult for you, but with practice with us, we'll do practice for history and communication. These two items or two stations, we'll do many practice for them. For what? To modify your language. Sometimes you will find your colleague is telling abdominal pain. We'll correct him. So don't worry. How to put in my mind all these non-medical terms by practice only. Go ahead, Dr. Muhammad. Thanks.
Right, thank you very much. So our first station is going to be self-discharge or discharge against medical advice. So before you enter the station, you will have 1 minute to read this scenario, okay? And it's a young patient who had a road traffic accident and he had an injury to his spleen. He was observed for 48 hours. He remained well, but the plan was for further observation and planning or possible splenectomy if there is a rupture of the hematoma. Okay, the patient is not happy to stay in the hospital. He wants to go home, and he has an important interview or some reason that he wants to go home for. He's also maybe facing financial difficulties because his wife is diagnosed with cancer. All right. So the first part of any station is you introduce yourself. So an intro, I identify yourself and identify the patient. All right. So hello, Mr. Obviously, you will have the name of the patient. Okay. I am Mo. I'm one of the surgical doctors. I've been told that you want to leave the hospital. All right. Can I ask you first why? So obviously, before trying to convince the patient to stay in the hospital, you need to find out the reason. So find out what the reason is, and then you can address his concerns and maybe you can try and convince him to stay. But don't try and convince him to stay first without knowing the reason, okay? So find out the reason, okay? Okay, so the patient here will tell you, my wife has breast cancer, and she has an appointment, and I want to be there with her. And he also may tell you, I have a job interview, and I need to be there for the interview, and so on. Okay. If he tells you his wife has breast cancer, then it's very important to show empathy, all right? Don't move on to the next question, or don't move on to the next step until you show empathy, okay? So you can say, oh, that must be very difficult for you and her, or, oh, I'm so sorry to hear about your wife. That must be very frustrating, or must be very difficult, and so on, okay? So after you do that, you can then justify why we need him to stay in the hospital, okay? All right. So you can say, I understand that staying in the hospital is very frustrating and disappointing, but you have to know that people are only kept in the hospital when absolutely necessary. So it's really necessary to keep you in the hospital. Otherwise, we would have sent you home, okay? And then the patient here will tell you, yes, I understand, but I have to leave because of, and he might tell you the same reasons, okay? So in this case, we need to explain the case to the patient, all right? We need to tell him about his case, okay? And that's our way of justifying why he needs to stay in. So after you do that, you will explain the case to the patient, all right? And this is the next step. So you will tell him, for example, Mr. John, let me explain your case, okay? You have what we call a splenic hematoma, which means a collection of blood around the capsule of your spleen. Here, the patient may ask, what is a spleen? And in this case, you may ask, you may explain to the patient what a spleen is. You may even draw like a simple drawing of a spleen, okay? Or you might just tell him. You can tell him a spleen is an organ which is present right here in the upper side of your tummy, okay? And you can point on your own tummy just to tell him, okay, where it is. And you can explain to him what a spleen is, all right? Anyway, so this was due to a fracture of your ribs. Your hemoglobin dropped by 1 gram, which gives the possibility of continued bleeding, which may lead to serious, okay, deterioration and danger to your life. So this is the justifying part. This is why we need to keep him in the hospital, because he can deteriorate and there's a danger to his life. And that's how we are justifying him staying in the hospital. All right. The patient here will tell you, I know my case, okay, but I told you about my circumstances, okay? I have to leave the hospital and so on. I cannot stay in the hospital. I've already explained to you and so on, okay? So now we try to find solutions. So number 4, maybe we'll find solutions for the patient, okay? So for example, if he told you that he has a job interview, then you can offer a solution that you can, for example, speak to his boss or speak to whoever is doing the interviews, or you can give him a sick note to show that he's been in a hospital so he can try to reschedule that interview, for example, okay? Or if he tells you about his wife's condition, then you can explain to him that it's very important that he looks after his own health, because if something were to happen to him, he won't be able to look after his wife's condition, okay? So he needs to be well first, and he needs to look after himself first so he can help his wife later. But if he doesn't look after himself, then he won't be able to help his wife, okay? And this is basically what we're doing. So I definitely understand your situation, but you have to look after your own health. If something bad happened to you, your wife's condition will be worse, as nobody will be looking after her. I can arrange with our social workers to find a way to give help to your wife or to help your wife until your condition improves. Okay? The patient here still insists on leaving the hospital. Okay? And of course, if the patient has capacity, then you can't really prevent him from staying in the hospital. Okay, but you need to make sure that the patient understands the risks. You need to make sure that the patient has capacity, and you need to obviously give him warning signs or give him a safety net so he can come back if anything was to happen. Right. So number 5 would be capacity and understanding. Okay. So if the patient still insists on leaving, then in this case, you need to assess his capacity and you need to make sure that he really understands. So what you're going to say is, okay, Mr. John, can you repeat to me what I've told you about your condition? So I'll know that you understand me, okay? Or so I'll be able to know if you understand me right or not, okay? Or so I know that you understand your situation. And here the patient will repeat everything. Okay, he will tell you about his situation. He will show that he understands it's a serious situation, but he still insists on leaving. Okay. In this case, you need to tell him about the DAMA procedure or the discharge against medical advice. And this is number 6. Because you can't discharge him medically, because his condition is serious, you can't discharge him. So he has to sign a form basically, or he has to agree that he is discharging from the hospital against the doctor's advice. Okay, so in this case, you will tell him, Mr. John, as I cannot discharge you medically, you will have to sign a legal document stating the exact details of your case and that continued admission was medically advised and that the potential sequences or risks or complications have been explained and that you take responsibility for any adverse outcomes or for any complications. Okay. In the actual station, he wouldn't actually need to sign a document. You just need to tell him that he needs to sign one, but he doesn't necessarily actually sign it. If it is there in the station, that's fine, he can sign it, but usually in the station, it is not there. Okay? So the patient here will agree to signing everything. And in that case, you need to give him safety net, okay, or warning signs. Okay. So you tell him some warning signs. Okay, Mr. John, if you felt that your state is deteriorating, like feeling drowsy or having unbearable tummy pain, I suggest that you should attend the emergency department immediately and ask them to contact me or contact the SHO in charge directly. Okay? Or you can tell him, if you feel that you're getting worse, if you're having any pain in your tummy, you need to come back straight away. If you feel sick, if you feel that there's any problem, or if you feel a bit dizzy, you need to come back directly to the emergency department or you need to call an ambulance. Okay? And this is your safety net. The patient here will thank you afterwards. Okay? And then the last step would be to summarize the station. If you have time, you can summarize. If you don't, then that's fine. Usually you have plenty of time. You have 9 minutes and it's a really quick station. So in the end, you just summarize the case. So Mr. John, you have decided to self-discharge. You're going to sign the appropriate documents. So I'm going to sum up what we've been through. You know that you have a splenic hematoma and that the medical advice is to keep you in the hospital. You understand the risks of not being in the hospital, which include becoming more unwell and a possibility or maybe a danger to your life. You have accepted the responsibility of those risks. Also, we've discussed what you need to do, what signs to look out for, and that you return to the hospital if you become more unwell. Okay. Sorry, can everyone see my screen now?
Yes, it's clear, clear.
Okay, so our next station is the consent for an OGD. Okay, so again, you will have also a minute to read this. This is a 60-year-old with a history of smoking and alcohol use. He presents with dysphagia. Your consultant has gone off for a meeting, and you're tasked or you're asked to take a consent for an OGD, okay, and a box and also dilatation under general anesthetic. Okay, good. So again, first thing is intro. So you introduce yourself. Hello, Mr. John. My name is Mohammed. I'm one of the surgical doctors. I've been asked to talk to you about an investigation we'd like to arrange for you. Can I ask you, what do you know so far about this? So before consenting the patient or before explaining anything to the patient, you need to assess the current knowledge or what the patient actually knows, okay? Because sometimes they might know a lot about the procedure and they only want to ask a few simple things, or they only want to know specific things. So you don't need to explain everything. So you need to first assess the knowledge, okay? So assess knowledge. So here you're saying, can I ask you, or what do you know so far about this? Or you can say, has anyone spoken to you about the procedure, okay? Or has anyone discussed this procedure with you before, okay? Or have you had a chat with anyone about this procedure? So on. You can say it in many different ways, okay? And something to note, guys, the way we write things here is not the way you have to say it, okay? You can use your own language, you can use your own terms. This is just a guide. Obviously, you can say it like this, but you can say it your own way as well. So you don't have to say everything exactly the same as here, okay? This is just a guide, okay? So after you ask the patient, he will tell you, I don't know anything, okay? Or no one has spoken to me, okay? All right, so here you just explain to the patient in simple terms what an OGD is. All right. So, Mr. John, this procedure is called esophageal which can be abbreviated to OGD. There is a camera which is called an endoscope, which will be inserted through your mouth down to your food pipe and then to your stomach along the first part of your small bowel. Okay, the camera will relay the image to a TV screen so we can have a look inside. We shall also make a widening in the narrow part of your food pipe, which has been discovered previously on the barium image. We may also take samples from the lining of your food pipe, which may help us in figuring out your case. This will typically be under sedation, which will make you will make you a bit drowsy, but you won't feel any pain, okay? And this bit about the narrow part of the food pipe, this is all written in the scenario that you have before you enter the station, okay? So this is all written in the scenario before you enter the station. All right. And now, obviously, the patient will have some questions or some concerns, okay? So the patient here will tell you, are there any risks, okay? Or the patient will tell you, are there any complications to this procedure, okay? And obviously, number 4, you will address concerns. So address the patient's concerns. or answer the patient's questions. And obviously, we all know that any procedure has its risks. So what you're going to tell the patient is no procedure is without risks. The possible risks include damage to the teeth from introduction of the scope or the camera. There's a risk of infection, such as a chest infection. There's a risk of bleeding from the sites of the tissue samples, or when we take the tissue sample, there's a risk of bleeding. And the most serious risk is cutting through your food pipe, which may need a surgical operation for repair. And this is a perforation. But obviously, we don't use medical terms, so we don't say perforation. We will say cutting through your food pipe. So instead of saying perforation of the esophagus, we can say it in a simple term. Okay. And obviously, you tell him all these risks, the patient will be a bit concerned. He'll be a bit worried. Okay. So patient here will be worried. Okay, he might say something like, that's a lot of risk, that's a lot of risks, or those are too many complications, I am afraid now, that sounds serious. And he might even say something like, I think I'm not going ahead with this procedure. Okay, and obviously this is a normal reaction. So you need to explain to the patient that because we've told you about all these risks doesn't mean they're going to happen. Okay, you just have to tell him about his risk, about the risks of the operation. But just because you told him about all the risks, that obviously that doesn't mean that any of them will happen. Okay, and that's something he needs to understand. So, Mr. John, listing those risks doesn't mean that they will essentially happen. My advice is to accept doing the investigation. It is very crucial in the determination of your case. Also, you have to know that only skilled and experienced surgeons are allowed to perform such procedures. Okay, so here you're just giving the patient a bit of reassurance. Obviously, you don't lie to the patient. Never lie to the patient in a communication station. You will lose marks. You might even fail the station if you lie. But a bit of reassurance is absolutely fine. So you just tell him those complications are not necessarily going to happen. Only experienced surgeons are doing the procedure. Okay. After that, the patient will ask you some other questions, sometimes some of them not related to the surgery. He will ask you, why am I salivating too much? Why do I have too much saliva? Basically, and this is because of the narrowing, okay, in his food pipe, which hinders or stops or slows down, okay, slows down your regular secretions to flow downwards smoothly, okay, because he has a narrowing in his food pipe. Okay, and then the patient will ask you a very important question, which you may get asked a few times in communication skills, and he's going to say, do you think it's cancer? Okay. And this is a very important question. Whenever you get asked that question, and obviously we don't know the answer, we're not sure whether it's cancer or not. So you can't really say yes or no. And you try to avoid answering in a yes or no answer, okay? So you can't deny or confirm, okay? So you have to be a bit diplomatic. Whenever someone asks you, do you think it might be cancer? Even if you really suspect that it is cancer, you can't tell the patient it's cancer until it is 100% confirmed, okay? If it is confirmed, then you can tell the patient. But if it's not confirmed, then you can't deny or confirm whether it's cancer or not, okay? I hope that's clear. You might even repeat that question a few times. May repeat the question. And every time he asks you this question, you also have to be diplomatic and you will answer the same way, neither confirm nor deny. Okay? So you're going to tell him, Mr. John, it's still too early to confirm that. We will have to wait until the results of this investigation appear, and probably we may need to do further investigations to figure it out, okay? So you try to be diplomatic, okay? Don't tell him yes or no. You can say, we're not really sure yet, and that's why we need to do this procedure, or we need to do this OGD, so we can take some samples, or so we can take a biopsy, and we can send it to the lab, and then we can try to find out what's happening exactly. Well, I can't give you an answer now until we do some further investigations, or until we do some further tests, okay? So neither confirm nor deny. Then patient will ask you, sorry, patient will ask you, when will the results come out? Okay. So usually the results appear within 2 weeks' time, okay, for a biopsy. So you can tell him that, but you can also give him some reassurance, or you can tell him that I understand your apprehension. I understand that it is very stressful for you, and we will make sure to contact you once it's available. We'll make sure to give you a phone call once we have the results. We'll make sure to let you know once we have the results, so on. You can say it in so many different ways. Just tell him that we'll let you know as soon as possible, basically. All right. Here you can close the consultation. Don't forget to give the patient some general advice. For example, he won't be able to drive after the operation because he will be sedated for the procedure. So he has to have someone with him to take him home, and so on. And you can also summarize in the end if you have time, like the previous station. If you don't have time, that's fine. Okay. So before you end, number 5 would be further concerns. Do you have any further questions? Okay, the patient will say no, and then you can summarize and give him some safety nets. Okay. All right. Sometimes the patient may ask you another question, which is not written here. So the patient may ask, will I need to be admitted? Will I need to be admitted after the procedure? Or will I need to stay in the hospital after the procedure? Will I need to stay in overnight? And so on. And obviously we know OGD is a day case procedure, so he can go home, but obviously we need to make sure that he has someone with him at home, or he has someone to drive him, someone to look after him in the first 24 hours, because he might be a bit drowsy after the sedation. So you will tell him, Mr. John, typically you will be discharged home after you regain consciousness, but you'll have to have someone to drive you home, or someone to look after you after the procedure. Okay, I hope that's clear.
Dr. Muhammad,
Yes.
I have some updates from Buzz Mrcs side.
Oh yeah, go ahead, you can tell us.
Okay, it's very important. I will share these papers for you in communication. Now, this patient for OGD is the patient himself. But if the patient, if the relative in communication, please before starting, you should ask the relative, do you have consent or not? Do you have take consent from the patient to discuss with you or not before discussing with him? This is very important. Okay.
Yep.
This is the first point. They are telling introduce yourself and gain understanding of what the patient understands so far. And you should introduce yourself And you should confirm that patient understand what you discussed with him, like this station. Explanation of the OGD procedure and the tissue sampling, it's helpful to draw a diagram if you can. Do it quickly. And this is updates. If you have diagrams, this would be better in OGD. Number 3, explain that it can be done under local anesthesia or sedation like what told. And advantage for every and disadvantage for everyone. Explain alternatives like barium swallow and X-ray, barium swallow meal X-ray. Expect a sore throat afterwards. We should explain after that one of the complications when you are explaining the consent for OGD, taking of consent, you should explain the hazards or complications that can be happen, like you discussed. And the risk is lastly bleeding, infection, damage to the teeth, perforation. Inform them when to be in BO and to take their regular medications if he's taking. Then summarize if necessary and keep checking that patient understand the information. I will share this paper. Okay.
Okay, thank you very much. Someone is asking how many stations we have today. I think we have about 7 or 8 stations. The first couple took a longer time because we were explaining how to do it, but then the last few stations hopefully won't take as long, so we'll get them.
مالك انت مش عارف مالك من بارتي انت مش عارف مالك من بارتي اوكي مالك you can take your time Dr. Muhammad مالك we will finish from all communication today okay take your time Dr. Muhammad because today is very important please let us finish within 3 hours 4 hours whatever should be finished properly okay continue Dr. Muhammad.
Lilia is asking if the patient wants to have the procedure under GA. Well, he will have that discussion with the anesthetist. He can also be diplomatic, okay? So there's no really right or wrong answer in communication skills. You can get around most of the questions by being a bit diplomatic or by avoiding them in a good way. So you can tell the patient, I understand that you want to have the procedure under GA. You may be able to have that discussion with the anesthetist, but usually we do this operation under sedation, and most of the patients do not, or all of the patients do not feel any pain, and most of the patients are not aware of what's happening. So it is very similar to a GA, but you can still discuss it with the anesthetist when he sees you before the operation. So you can be a bit diplomatic. You can explain to him that it's not going to differ much because sedation is very similar to a GA from the patient's point of view. In any case, they won't remember anything and they won't know what's happening around them. And he's not going to feel any pain anyway. So it's very similar. So you can explain to the patient it's not going to really make much of a difference, but he can discuss it with the anesthetist. Okay. And obviously, the problem with the GA, if he needs intubation or whatever, then that's not going to be really possible if we're doing an OGD. But again, he's going to have that discussion with the anesthetist, okay?
Yes, excellent point, Dr. Muhammad. Because already this procedure can be under sedation or under local. If asking about GA, yani, try to escape from that. You can't tell no, you can't tell yes. So after discussion, you will tell your job is CHO or ST1, you have no authority to decide that. So very important to escape from this question by, okay, we will discuss with anesthesia if it's possible or not. And I will discuss with my consultant. I think this is a good idea to escape from the question by this way, okay?
Good. All right, shall we move on?
Go.
Everyone happy to move on? All right, here you will speak, you won't speak to a patient, you'll speak to a parent, all right? So here you speak to a relative, and this is an anxious parent, okay? And we have 2 similar scenarios with an anxious parent, okay? So the scenario here is the son with a splenic rupture, okay? And this is a very important station because we have very important things here in this station that we shouldn't miss. The father has approved the operation, okay? The mother is crying and demands to speak to a consultant, okay? And I had this station in my exam, okay? And it's a very, it's a difficult station because as soon as you enter the station, you won't have a chance to introduce yourself. So in my exam, when I entered the station, the mother was standing, okay? She was right there. As soon as I opened the door, she was standing in front of me, and she started to speak first before I had the chance to introduce myself or anything, okay? So here, the mother actually spoke first, and she was very anxious, and she was shouting, okay, and she was standing. Unlike most of the stations where the patient or the relative is sitting down in a chair, she was standing right there in front of you, and she wants to know what's happening. What's happening to my son? What's going on? Is he going to be all right? Is he dying? Can you please let me know? I want to see him, and so on. She's very anxious. She's all over the place, and you don't even have a chance to introduce yourself. So your job here is to stay calm, okay? So stay calm and try to turn things around to your advantage, okay? You need to follow our steps that we followed beforehand. You need to introduce yourself, you need to invite the patient to sit down, and you need to have a discussion. You can't have a discussion while the parent is standing. You will lose points, you might fail the station. If you continue the station while both of you are standing, it's not good. You need to sit down first, okay? So what you're going to say is, hello, I'm Mo. I'm one of the surgical doctors. I understand that you're very anxious. I understand that this is a very stressful situation for you. Okay. I will tell you everything about your child's condition. Okay. But can you please have a seat so we can discuss everything in a bit more detail? All right. And invite basically, sorry, go ahead.
Dr. Muhammad,
Yeah.
sorry, because already this station, maybe it will start by another way.
Yeah,
يعني
of course.
please
Yeah, yeah.
يعني how to start? Can I start by this way? Sorry to interrupt
No,
you.
no, no,
يعني
it's
sorry to
absolutely
interrupt you,
fine.
but I
Go
want
ahead.
the starting of this station is very, very important. If you will start properly, I think this station will go smoothly. Okay. يعني one of them, like Dr. Muhammad told, I am Dr. Muhammad, one of the surgical doctor. I apologize that we can't contact you and take a seat like this way. Take a chair and sit. This one, other, it will be written outside the name of the patient. It's the name of the mother. Okay. Sometimes it will be written. So you will go directly. You will go directly, Mrs. Elizabeth. I am very sorry that we have it here. No warning. Here, you can't introduce yourself by this way. You will start by this way. Call her and apologize that you didn't contact her before going for operation. And I am doctor, and start to introduce yourself. Okay, here is very important. First, you should take attention of her that you know her name, that she is waiting you. This is very important. Start by this. If her name is written outside, you can start by this way. Okay. Starting of this station is different from person to person and from actor to actor. So try in this communication to understand the rules only. The rules that if patient is shouting or angry or anxious, you should ask to sit first and sit also, and you should sit also. If she's standing and shouting with you, don't stand. You should sit also. Don't stand. Okay, proceed, Dr. Muhammad.
Yeah, yeah. So, like Dr. Salah said, you can. The point is staying calm and trying to get the relative or the mother to sit down so you can have a discussion with her. And you can do this in many different ways. Like we said, this is only a guide. And obviously, you can say it like this or the other way, and you can say it in your own way as long as you're sure that you've got good communication skills, then you can make up your own way of saying it. There's no right or wrong answer as long as you get to the point and you do the important stuff. So stay calm. And then you've introduced yourself. So we've done that. And you've asked the patient or assessing or the relative the knowledge. So you assess the knowledge. What does she know so far? So after you sit down, okay, assess knowledge. Okay. And you're trying to find out what she knows So you can explain to her what's happened, okay? And she will tell you, I don't know anything. I'm very worried. Please let me know what's happening. I want to see my child, and so on, okay? And here you can explain, but this is essentially a breaking bad news station, or what we call BBing, breaking bad news, okay? And in breaking bad news, you have to follow 3 steps, okay? So the first step is you fire some warning shots, warnings, okay? The second step is you tell the patient or the relative the bad news, okay? And the third step is silence. And well, I'll explain what that all means in a moment. But this is how you break down any breaking bad news station. First thing is give the patient a warning, okay? And then you give him the bad news, and then you stay quiet, okay? And wait for him to speak first. So, Mrs. John, your child apparently fell off his climbing frame and probably seriously harmed himself. So this is our first warning sign, okay? I apologize that you couldn't see him before being taken to theatre, but the case was an emergency and we could not wait. So the case was an emergency. Again, this is another warning sign, okay? The mom here will say, is it serious? Okay, and like we said, here you have to be honest. You cannot lie to the patient, okay? And here, unfortunately, the scans we have made when he came in suggested that he had a ruptured spleen, okay? And again, you can explain what a spleen is, okay? And he's now being operated on to fix it. So he needs an operation. And unfortunately, all of these are warning signs. And again, body language is important. Eye contact is important. We've talked about them. This is communication skills. It really doesn't matter much, really, your medical knowledge, as long as you say something appropriate and you have good communication skills, you will pass this station. So eye contact, body language, and empathy. They're really important, okay? So show that you're sorry, show that you're sad, talk in a sad voice, and so on. Okay. Now, mom here will start, sorry, again, mom will ask you, so what's going to happen? Is he going to die? And so on. And here you can say ruptured spleen is definitely a serious condition. Okay. And that's why he was taken urgently to theatre. You have to know that he is in very good and experienced hands. However, his condition remains serious to the extent that it may affect his life. And this is the bad news, essentially. So these are warning signs, okay? And then the news is, the bad news is it may affect his life, okay? Because a ruptured spleen in a kid is very serious, okay? And you have to be honest with the patient. You cannot lie. But again, you have to say it in a diplomatic way or a nice way, show some empathy, okay? And step number 3 is silence. So after you say that, you stay quiet, okay? Here the mother will start crying. So she will start crying, okay? Sometimes you have tissues in the station. You can offer her tissues, okay? If you don't have any tissues, then do anything, stay quiet, silence, like we said, okay? So offer tissues, keep silent. The problem here is most candidates feel a bit awkward or don't know what to do when the mother is crying, and they try to reassure her or try to give her some false reassurance. Oh, don't worry, he'll be fine. He's going to be absolutely fine. And unfortunately, that's something we're used to in our culture. But if you say that, you will lose points because you don't know that he's going to be fine. You cannot promise the mother that he's going to be fine. You can't tell her that he's going to be fine, okay? You have to be honest with her, and if she's crying, all you can do is offer her tissues and stay quiet. Okay, but don't try to give her some false reassurance, or don't try to talk or well, change the subject or anything. Okay, so it's very important to stay silent. Okay, after that she will start talking. Okay, and she'll move on to something else. So she will say, what did his father tell you? Okay, and this is the second part of the station. So the first part of the station was a Breaking Bad news station. The second part of the station is a safeguarding issue. And again, if you miss this, you will lose half of the station. Okay, I actually had this station in my exam. So she will move on to the second half of the station. She's going to ask, what did his father tell you? You will tell her, his father told us that your child was playing in the garden when he suddenly called out in pain. He's had fallen from height. He noticed the big bruise on the left side of his chest, so he called an ambulance. All of this, of course, is written in the scenario before you enter the station. Okay? And then the mother will give you a hint. She will say something very important. She will say, this is not the first time. What does this mean? This is very important. Okay, and then she might tell you something else. He is not my current husband, he is my ex, and so on. Or she might say he's not the biological father, he's my partner, whatever. Okay, she'll give you some hints. Okay, so if this is not the first time and the child is in danger and he's been hurt, then you have to take this comment very seriously. Don't ignore it. If you ignore it, you will lose points. You lose half of the station. So because this is a child, we have to make sure that he's safe. So I will have to share this information. In any case like yours, you have to make or take extra precautions to ensure that your child is safe. We will take some standard procedures like finding out about your child's situation at home. Also, we'll need to involve child protection services or a child protection consultant. We routinely involve child protection services to make sure that anything we do will be in your child's best interest. And again, you can say it in any other way that you want. You just need to make clear to her and to the examiner that's listening that you've noticed that there's a safeguarding issue and that you'll take the necessary precautions. You can tell her, I will have to speak to my consultant about this, and you may need to involve social care or social services to make sure that your child is safe. And this is basically a short way of saying it. But as long as you make that point, you'll be absolutely fine. Okay. Mom here might say, what is the function of the spleen? Okay, and you can explain to her what a spleen is. You can draw a diagram if you want. So the spleen is an organ present here in your tummy. It has functions in the body's defense mechanism. So if the spleen is going to be removed, he will need to be vaccinated after that, and so on. Okay. How long will he stay in the hospital? Obviously, we have to make sure that the child is safe first. So our first priority is the child's medical care. Okay, we'll make sure that he will make a good recovery. We will not discharge him until we've undertaken a full clinical examination. Okay, and this is might be due to sometimes we do a skeletal survey for any suspected non-accidental injuries. Okay. And also, we need to make sure that he is safe before he goes, because we said that we will speak to child protection services, or at least you will speak to your senior about it. So we need to make sure that he's safe from that point of view. We need to make sure he's medically fit, all that other stuff. We need to make sure there are no other injuries, such as doing a skeletal survey and all of that before he can go home. Okay. Mother will say thank you. You can ask her if she has any further questions. She can let you know, and that's it really. She also might ask you another question. Okay, she can ask you, how long will the operation take? Okay, or can you please go in? Can you please go and check? So she wants you to go into the operating theatre to check to see what's happening and so on. Okay. And again, it's communication skills. You don't really have to give the absolute right answer. You can answer it in a diplomatic way. And you can say, it will be very difficult to determine how long the operation will take. Okay. And you can also apologize that you won't be able to go in and check. You can say, I'm afraid I can't go in, I can't go and check, okay, while the surgery is taking place, because I don't want to interrupt the surgeons, I don't want to disrupt the surgeons or disturb the surgeons and so on. So you can't really go into the operating theatre now, apologize to her, okay? And that's it. Is it clear so far?
Yes, I
Dr.
have two
Salah, do you have
questions.
any additions?
Yes, I have two questions. In previous station, I just remember now, and this
Mm-hmm.
station. In this station, he asked before, what is vaccine? What is vaccine? So when you are telling that the rule of spleen, the rule of spleen, very important here to tell that patient will take not to changes. Examiner was shouting for lifelong. Okay, to remove lifelong protective antibiotics. Uh, I discussed with them in part A about penicillin antibiotic after spleen. It will not be lifelong, it will be till 16-year-old. I think this is a child, so you can tell and will receive prophylactic antibiotic plus vaccine.
Instead of saying lifelong, we can say long term, for example.
Long term, long
Long
term till
term
16.
antibiotic.
Yes. This
Yep.
first point about the antibiotic and the vaccine should be given after operation by 2 weeks. You should mention also that patient will take vaccine after operation by 2 weeks. This is
Yeah.
very important to mention because asked, يعني asked Rizwana, I remember Rizwana, she was in our course, asked her frankly about vaccine, when you will give this vaccine. I will share paper for the vaccine also, should be after operation by 2 weeks. Then what is vaccine? What is vaccine? You can write now, anybody can write and then share in the group. Vaccine is substance used to stimulate production of antibody and produce immunity against disease. A substance used to stimulate production of antibodies and produce immunity against diseases. Okay, this for this station and all finished, mashallah. Previous station about OGD, you have new question asked. Patient telling is asking, I will stay in the hospital or I will go home after OGD. You will tell him if patient under sedation, and you know the patient under local or under sedation. Okay, if under sedation, you will tell, you will wait until the effect of sedation ends, and when you will be discharged, you want somebody with you to accompany you, and you are not allowed to drive. If patient in OGD, asking, should I stay in the hospital or I will go, you will tell, you will wait until the effect of sedation ends, and you will be discharged with somebody to accompany you to your home and not allowed for you to drive. تمام. These are the two questions. Okay, continue, Dr. Muhammad. Thanks.
Thank you. Some people are asking, is there enough time to go? Yes, there is enough time in the previous station. 9 minutes is plenty. I had the station, I finished all the questions, and I even sat quiet for about 30 seconds in the end without doing anything because the patient or the relative didn't have any further questions. The mum, we finished the consultation even early. So 9 minutes is plenty of time. Just to know, they not necessarily they're going to ask all these questions. You will answer the questions that they ask you. Okay, and then when they're done asking questions, that is it. You will ask them, do you have any further questions? Do you have any further concerns? If they say no, then that's it. That's the end of the station. You can say thank you and then sit quietly until the bell rings and you can move on to the next station. Okay, so they don't always ask all the questions, but even if they do, you have plenty of time. You have more than 9 minutes, as in, sorry, 9 minutes to go through all the questions. Okay, so this station is another anxious parent, and actually I have the preparatory station. I have the preparatory file for this, so I'll share it with you. Okay, can everyone see the prep station? So like we said, in communication, you will have a preparatory station beforehand. Okay, this is for every communication station. And this is an example of the notes that you will find inside one of the preparatory stations. Okay, so this is what's going to be written outside. Okay, before you enter, you are the SHO on call for emergency surgical care. A 10-year-old girl has been admitted as an emergency with peritonitis. She's been unwell for 2 days and very unwell for 1 day. The child is extremely ill. Perforated appendix is suspected. She's being resuscitated by your registrar before being taken to theatre. Your consultant, Mr. Mann, is on his way in from home. He will be performing the operation. You have been instructed to see the child's father and explain the situation. You did not have an opportunity to see the child yourself before she was taken to theatre, okay? And then when you enter the station, this is what you'll have. Okay, you will have the case notes. Okay, so like any other hospital notes, obviously you'll have the hospital number, surname, title, first name, so on, date of birth, address, and all this stuff. Okay, and then you will find some entries in the notes, and you have 9 minutes to go through them. And like I said, you have a piece of paper and a pen if you want to write down some stuff so you can remember. Okay, but it's not really necessary. And I don't really like it because I like to maintain eye contact while I'm speaking to a person rather than looking down at my piece of paper. Okay, but yeah, you can write some stuff down if you want. So first thing to look at is the date and time, and this is important because the notes are not always in order. Okay, so you need to look when this was taken. Okay, so here someone says a 10-year-old girl sent in by the deputizing service, which is like an ambulance. There's a vague history from the neighbor, father on his way, or mother on her way, too distressed to give any useful history, generalized abdominal pain for 1 or 2 days, for the last 6 hours, pain in the right iliac fossa, vomited once yesterday, so on. So you read these, okay, past medical history fit in well, no medication, no other siblings, lives with father or mother, and so on. So these are notes. And then on examination, temperature 41 degrees, pulse 120, rapid shallow breathing, chest clear, mouth very dry, abdomen very tender, right iliac fossa, generalized guarding, no bowel sounds. Okay, and here's the plan: IV fluids, bloods, and Miss Sparrow to see. So this is the plan, and this was written by John Smith, and he's a foundation year 1 doctor. Okay, so he's just fresh out of medical school. Obviously, the foundation year 1 doctors, they see the patients first, and then if they need someone senior to see, they will speak to someone senior. In this case, he said Miss Sparrow to see. Okay, so this is most likely a registrar or consultant because they have Miss rather than doctor, and that means they have MRCS. Okay. So moving on, 15 minutes later, okay, Miss Sparrow, who is a registrar, okay, she said, I agree to the probable appendicitis with generalized peritonitis. The patient needs urgent resuscitation. I will ask Mr. Mann to come in. So he is now probably the consultant, as you know from the scenario, and get the on-call anesthetist to see her. And we'll probably need an on-call anesthetist to be around. And I will also get the pediatric registrar to come down and help with the resuscitation. Okay, so Miss Sparrow has written all this. Obviously, you have 9 minutes to read it, which is plenty of time. You will have time to read it at least 2 or 3 times and memorize it. Okay, and then this is a message from a registered nurse. Okay, so sister has written that the on-call anesthetist said that and he will be here and so on. Okay, and that's it. And then you have blood tests. Okay, again, notice the time on the blood tests. Okay, you will have a time as well when the blood tests were taken. So here the blood tests were taken at 10:30. And here you can look at serum albumin, alkaline phosphatase. You'll have the normal values. So we'll have a bunch of blood tests. If you want to write some stuff down, that's absolutely fine. You can notice here that the CRP is 50, so CRP is a bit high. Probably have also white cell count of 20. So that's also a bit high. Neutrophils are a bit high. So it confirms the diagnosis of appendicitis, okay? A blood gas, you might have a blood gas as well. And that's it. Those are the notes. So in total, 6 pages, and you have 9 minutes to read them. And some of these pages will take like 15 seconds to read. So honestly, you have plenty of time and you can take notes. Okay, so you'll know everything about the patient before you go into the station. Is it clear so far?
Please share this file for them in
The
their
file
drive.
is already in the drive. Whoever is asking, I'm sure. Does anyone even look at the drive?
Uh, by
I'm
the way,
sure it's
also,
there, but
besides these files in the
I'll have
drive,
a look. If it's not there, I'll upload it. But I'm pretty sure it's on the Google Drive. Okay, I'm not going to share it on Telegram. It's
no,
on the
no,
Google
no,
Drive.
Malik. No, Malik, no, no, not in Telegram.
Anyway,
Not Telegram.
um,
Dr. Muhammad, also before continue,
yeah,
I wanted to confirm about videos. You
the
have
videos are on
amazing
the Google Drive
videos.
as well.
Videos are amazing. I'm not sharing videos now in the group. I'm not sharing videos. Videos, by the way, are very, very important. This is from Glasgow Real College. These videos are amazing. It will help you a lot in this exam. Okay, Dr. Muhammad, continue.
Good. So after the 9 minutes, after you read the prep station, after the 9 minutes are over, you will go outside and you have another minute to read the scenario again, and then you go into the actual station for 9 minutes. Okay? So again, you go in, first thing, introduce yourself. So intro, okay. Hello, whatever, Mr. or Mrs. John, whoever is in there, I'm Mo. I'm one of the surgical doctors. I was asked to speak to you about your child's condition. And again, you assess the knowledge, assess knowledge. So can you tell me what you know so far? Okay. And here the mother will tell you, or the father will tell you, I left my daughter with the neighbor. Okay, she will tell you some other stuff. She feels guilty, essentially. She feels guilty. Okay, and she's also a bit worried. Okay. So here, obviously, because she's feeling guilty, it's not her fault. It's appendicitis. It's nothing that she could have done. So you have to give her some reassurance. First, you don't have to feel guilty because this could happen anyway. Your daughter was brought in by your neighbor or by the ambulance because she was complaining of tummy pain. Our initial investigation revealed the suspicion of acute appendicitis. Okay, and she was managed by our registrar and received some fluids through her veins and some antibiotics. Okay, we are now waiting for the consultant who will operate on her. Okay, so and then you obviously address any concerns or questions that the parent may have. Okay, so the parent will say, are you sure about the diagnosis? Okay. And obviously, we can't be 100% sure about appendicitis until we open up and see. And that's essentially what we're going to tell the parent. We are suspecting acute appendicitis, as this is a common condition, and also her signs and symptoms denote this, or her signs and symptoms make us highly suspicious of appendicitis, but we cannot be certain 100% until we open and see. And that's the truth. Again, be honest with the patient, don't lie. You cannot say 100% it is appendicitis. If you tell the parent in this scenario, yes, we are sure it is appendicitis, then you will lose marks. And this is where candidates fail because they're not being honest. They're afraid to be honest. They think if we say we're not sure, then it might look bad. Well, no, you need to tell the truth. Okay, in this case, we're not 100% sure, and that's a fact, but that's normal, okay? We're highly suspicious, and that's why we're going for surgery. Surgery is justified, but we can't say 100% until we open up, all right? So parent here will ask, is it dangerous? Well, in children specifically, again, you have to be honest again. In children specifically, there is less fat inside the abdomen because basically they have a less developed omentum, okay? But you don't tell that to the mother, you just tell her there's less fat inside the abdomen, so a perforation can be particularly dangerous, okay? And again, you're being honest, we're not lying, so yes, it can be serious, it can be dangerous, but you can give her here reassurance, but be sure that Mr. Mann, for example, is a very experienced surgeon, or be sure that you're in very good hands. You don't have to mention the consultant. You can say, be sure that you are in very good hands, or your child is in very good hands. We'll look after your child. And so on. So give her a bit of reassurance, but also don't lie. Tell her that it can be dangerous. Okay, and in such case, your child may go to a higher care area, which is most likely a PEDS HDU after the operation. That's common for operations like this to go into HDU afterwards. Okay, and not back to the normal ward. The parent here will ask about a scar. Will it leave a scar? And of course it will, and your procedure will. So you'll tell her a small horizontal scar or a small horizontal wound will leave little scar, okay? But if we need to expand the wound, that may leave a bigger scar. Instead of saying disfiguring, we can say may leave a bigger scar. Because of course we know if there is a rupture, sometimes we might need to extend the incision a bit further. We might need to do a laparotomy if things get out of hand. So if we're just doing appendicitis, then it's going to be a small scar. But if we need to extend it because of any complications, then obviously it will be a bigger scar. And again, be honest with the parent and tell her that, okay? And you can also give her reassurance again. We will try to leave or make as little scar as possible, okay? Obviously she's a girl, she's a bit worried about that. Or you can tell her we will try to close up the wound very nicely as to leave very little scar. Just anything you want to say, really, a bit of reassurance, okay, if she's a bit worried. Okay, the parent here will ask that she read, I read on the internet, and that's always a bad sign, isn't it? I read on the internet that infection can block reproductive tubes. Okay, is that true or is that correct? And actually it is true to some extent, because if there is adhesions, it can actually block the reproductive tubes in young girls. But again, it is going to be just on the right side, so the left side is not going to be affected, okay? So you can tell her probably in severe infections or in severe cases, there is a chance that the reproductive tubes may be blocked, or probably severe infection can block the reproductive tubes. So future subfertility, not infertility, subfertility may happen, okay? But that's not certain at the moment, okay? And it's only a chance that there is a severe infection, and it does not always happen, okay? So you can reassure her again. And that's it. So again, she won't have any further questions. So any further questions? She will say no, thank you, and that's it. Number 5, just summarize, okay, and end the consultation. Okay, you don't have to summarize if you don't have time, but it's always a good idea to summarize if you want. Okay, good. Any questions?
Yes. Okay, look, Muhammad, regarding for summarize for any station, I think you will have no time if the station started to be complicated with you. But examiner will consider that. But please, if you will finish early, especially in communication, this is not good sign to finish within 6 minutes and you have 9 minutes. So if you have time, better to summarize. Don't forget this point. Because I have many experience of candidates that they didn't summarize. They forget it. If you will finish early, after 6 minutes, for sure, you should go for summarize. Okay, but if communicated station and the actor started to struggle with you, so you have no time to summarize, it's okay. Examiner will consider that. Okay, this is regarding summarize. Good, Dr. Muhammad.
Good. So I think we have a few more stations. We can do this station and then take a break if anyone's tired. Okay. So this is an angry patient. And we have
Continue. These people, they are adapted from part A to take 6 hours. 6 hours meeting. Continue.
yeah. Okay. So an angry patient, and we have 2 stations with an angry patient. Okay. So the scenario here is a patient with a post-traumatic meniscus injury, so an injury to his knee, okay? And he was planned to have an arthroscopy, okay, a knee scope, and it was cancelled twice, or it was cancelled once before, it doesn't matter, but the point is he was cancelled before, and now, because there's an emergency case, he will be cancelled again, and obviously he is frustrated. And your task is to go speak to the patient, okay? And again, you will have a preparatory station or preparatory bay. You can, like I said, notice the dates because they're not always in order, okay? So you can read the prep notes before you go in. So again, introduce yourself. Okay, good morning, Mr. John. My name is Dr. Mo. I'm one of the orthopedic doctors, or I'm one of the surgical doctors. I'm one of the SHOs. Whatever it says in your scenario, okay, it will be different. I'm covering for my consultant. Okay, I understand that you've come in today for your knee operation. Okay, and that's it. Here, actually, the actor sometimes he may stand up and start gathering his things, and he thinks that he's going for the surgery, so he's acting. He thinks you're coming in to tell him that we're ready for you in the operating theater, or he thinks that it's his time for the operation, okay? And he starts gathering his things, okay? And then here you have to obviously apologize. Mr. John, I'm very, very sorry to tell you this, but unfortunately, my consultant has been called away for an emergency case, okay? And we will be unable to carry out your case today. So you have to apologize, of course. And here the patient will be very angry. Okay, and he may stand up this time for real, but because he's angry, not because he's gathering his things. Like we said in previous station, if the relative or the patient stands up, you don't stand up, because both of you will be sitting in the chair. When you tell him his operation has been cancelled, he will be very angry and he might stand up and start shouting at you. And your job is to stay calm and not to stand up. If you stand up and confront him, then you will lose points. Okay, so stay in your seat. You can stay sitting down, all right, and then ask him nicely or in a good way to sit down so you can continue the consultation, okay? But don't stand up and don't shout at each other, because he will stand up and start shouting at you, and you don't need to stand up, all right? So again, Mr. John, I apologize. I can see that your knee has been really troubling you. It would have been nice to have the operation done today. I understand your frustration, as I see from your notes that you were cancelled once before or twice before. However, surgical emergencies have to be prioritized, and this is why my consultant was called away, and I'm very sorry for that. Okay? Good. After that, he will say, I'd like to speak to the consultant. And of course, we just said he's been called away for an emergency, so he can't see him. So sorry, as I told you, he's busy now, right now with an emergency case, and he will be unable to pick up my call, or you won't be able to see him because he's dealing with an emergency case. Or I do apologize, but he's currently busy with an emergency case and you won't be able to see him. Okay? And the patient here will ask you, can I choose another consultant to do my operation? And of course, it is his right, because this is an elective procedure, and it's not an emergency case, so he can choose the consultant. That's absolutely fine. But the problem is, he won't have the surgery done today either. So you have to explain that to the patient. Okay. So, Mr. John, it's your right to choose your doctor. That's absolutely fine. But I'm afraid that will also be time consuming, as the new consultant will have to study your case from the start and will still be unable to do your operation today. Okay, so you have to tell him it's absolutely fine if you want to choose another consultant, but that's not really the best option for him, because the other consultant has to go through his notes, has to review the scans, and maybe has to see him in outpatient department first to discuss the surgery. And again, it's not going to happen today. So you just tell him really, and it's up to him. Okay. Then the patient will ask you, can you do the surgery for me? And obviously, you are a junior doctor, so you can't do the surgery without supervision, and that's what you're going to tell the patient. I'm so sorry, but I'm not authorized to do such operations without supervision. Okay? The patient here will try to put you under some pressure. Could you give me an exact date when, or for example, when will my operation happen, or when will I have my operation? Okay. And of course, he cannot give him a date. That info is not in your notes, it's not in your scenario, so you're not able to give him an exact date. So you tell him, I cannot give you the next available date just now. We will call you once we put in a date, but I promise I will mention your circumstances and emphasize that, or emphasize the importance of having you listed in the next possible session. Or you can say, I will mention your circumstances and that you've been cancelled twice before, so you will have a higher priority next time. Okay. But we'll give you a call as soon as possible. Okay. And then, can you guarantee, he will say, can you guarantee that it won't be cancelled again. And of course, you cannot guarantee that. So you're saying, I'm so sorry, sir, but if such an emergency should rise again, it will need to be prioritized. And again, because his operation is not really an emergency, so if he were to come back, and there was another emergency that day, or there was an emergency case, then we'd have to prioritize that. And I'm sure he understands. And we have this every day in the hospital. Patients get cancelled. That's just normal process. And I'm sure all of us had to speak to a patient at some point to apologize for the operation being cancelled. I had to cancel the same patients 3 times over this weekend. So the last weekend, I had to cancel the same patient 3 times, Friday, Saturday, and Sunday, because we had an emergency case 3 days in a row. And it's something that you get used to, and it's a simple station. Okay, so don't get worried about it. So again, explain to the patient, if such an emergency case should rise again, it will need to be prioritized, or we have to prioritize life or limb threatening situations, and I'm sure you understand, sir. Okay? The patient here will tell you, I'm in severe pain. I can't work. And so on. So show some empathy here because he's in pain. Oh, that must be very difficult for you. I understand that is very frustrating. And then offer him some solutions. Okay, so if he says he can't work, then you can say, I can write a letter to your employer, or I can give you a sick leave or a sick note so you can give to your employer so you can take time off work. Okay, or they can put you on light duties or amended duties for your work. Okay, so you just offer him some solutions, show some empathy, offer him some solutions. Okay. And even you can go as far as saying, if you want, I can call your employer for you, but that's not really necessary as long as you give him a sick note or a sick leave. Okay. Will the delay affect my knee? The patient is going to ask you. Obviously, if there is a meniscal injury and it hasn't been repaired and he's walking on it, it will cause some wear and tear. However, he should remain active with non-weight bearing exercises such as swimming to keep the muscles strong around his knee joint. You can also tell him that you can refer him to a physiotherapist who will recommend or give him some good exercises to strengthen the knee. Okay. You can also offer him some painkillers if he's in a lot of pain, and so on. Actually, he's also going to ask about that. So here's going to ask, I'm taking diclofenac, which upsets my tummy, okay, or causes problems with my tummy. And here you can offer him a different type of painkiller instead of the diclofenac, okay. And that's it, really. That's the end of this station. Dr. Salah, did you want to say something?
Yes,
Yeah.
we have many questions in this station, and it was the worst in Oman. I remember our candidates, they told me about this station. First question about if I can raise a complaint. I think you told this question before.
Oh
You
yes,
can
I
answer it.
answered that before last course. So, any complaints in the hospital are dealt with by PALS. Okay, so PALS. Okay, that's Patients Advice and Liaisons Service. And if you work in the NHS or if you work in the UK, when you enter the hospital, there's usually a PALS office, and all the patients know it. So if a patient wants to file a complaint, they go to this office and they deal with patient's complaint. So they deal with the complaints, okay? They offer advice and they offer confidential advice basically, and they will tell the patient how to deal with the complaint. So what you can tell the patient is, if he wants to file a complaint, you will tell him, it is within your right to file a complaint. I understand this is very frustrating for you, but you have to understand that it is, well, basically, not our fault, really. It's just an emergency case and it's out of our hands. But again, if you want to file a complaint, then I can direct you to PALS and they will give you some advice and they will deal with your complaint. So this is what you need to tell him. Do you have
Yes,
another answer for it?
yes,
Yes,
yes.
yes,
Very
go ahead.
important here. If he's asking to complain your consultant, ما تبيعهوش يعني الكونسلتنت تطلع روحك ومغلبك، ما تبيعهوش تقول له يلا اشتكيه. If this patient is asking me, I wanted to complain your consultant or your head of department, I will say yes, take the paper and complain him. But in communication, this is different. So you should explain first. Explain that you have emergency and your consultant has emergency for that, and this is your right to complain. And after explaining your situation, you can give him the right to complain and direct him for BALS, PALS. And I wrote this abbreviation for what in the group. Till now, this session is going smoothly by this way, and all the questions are repeated. I remember this session came for me. Actor was very happy when I told him. He told me about his sick leave is finished, and he can't. He's postman, by the way. He can't do his job. I told I can give you sick leave for that, and I will refer you for physiotherapy to keep your knee mobile and strengthening for the quadriceps muscles or the muscles of your knee. You will tell strengthen muscle of your knee. Don't tell quadriceps, by the way. Strengthening muscles of your knee by swimming and cycling. You will explain that for him. He told me, and if you want me to contact your director for your that cancellation of your surgery, he told me, doctor, this will be very nice from you. You can contact him. Yes, I will write letter for him that you need sick leave, and if you want me to contact him, it's okay for me. And he's very happy for that. I don't know is it correct or not, but impression of the examiner is okay for that. Because sometimes in communication you will surprised by question for the first time. Okay, about Oman last time exam, he's concerning about pain management and gaining weight. Yani he's telling that all medications you are giving me not improving me. He wants morphine. He wants tramadol or morphine. Tramadol, I think. He's in tramadol. He will tell you frankly, okay, I am not improving with normal analgesia. So you will offer for him weak, according to analgesic ladder, you are following but non-steroidal anti-inflammatory, which is not improving him. So you will go for weak opioid. The next step for analgesic ladder, which is tramadol. He will ask you, doctor, please, I read about it that I can be addict. This will make me addict. So Muhammad, what will be the answer for this?
So first of all, if the patient is in pain, obviously you will give him stronger painkillers, as in following the WHO ladder. Okay, so if he's on simple painkillers, then you will offer him a simple opioid such as codeine, which is what we do for a start. So paracetamol and codeine. You offer him cocodamol. If he tells you cocodamol isn't working, what I usually do personally is I will speak to the acute pain team. So whenever I want to prescribe strong opioids, I will speak to the acute pain team and they usually come and deal with it. But in this case, you can tell him, Mr. John, we can offer you some painkillers. I can speak to my senior to see what strong painkillers we can offer you. I'm sure we can offer you something stronger because our priority is you being comfortable and you being not in pain. So if you need tramadol, I'm sure we can sort it out for you. And if he asks about addiction, you will tell him that we will give you a small dose which shouldn't cause addiction, and we give it to patients who are in severe pain and it doesn't cause addiction, and will only give you a specific number of tablets until you have, for example, your procedure or until the acute pain subsides or settles down, and then we can then give you some less stronger painkillers. And that would be my answer, but if you've got a better
Yes,
answer, then you can tell us.
yes. So for prescription narcotic in UK by SHO can be done or not? This is my question.
Yes, it can, of course, yes.
after discussion يعني I agree for after discussion with pain management team
Yeah.
and
So
with
yeah,
my
we
senior.
the FY2s, the FY2s and the SHOs, they prescribe narcotics all the time, but usually it is a controlled medication. They have to write it in a specific way, okay? And usually they speak to a senior first, but they can prescribe it. But if it's an unusual situation, then they speak to a senior, but they have the right to prescribe it.
Yes, I think this is a proper answer for this question. Don't tell you according to your position. Don't tell okay I will give you or this will not cause addiction. You will tell I will give you by simple or small dose for narcotic, small dose, and after discussion with my senior and with pain management team. I think this is accepted answer. This for this question. Other question, he's telling you, doctor, because I am sitting at home, I started to gain weight. Is this okay
Yeah.
for me?
Yeah, so again, I will tell him, I understand this is very frustrating for you, and because you're in pain, you're unable to exercise, but you can do some non-weight bearing exercises such as swimming, which shouldn't be as painful as running, for example, or cycling, and that will help you lose weight as well. And we can get you to see the physiotherapist, which will give you some exercises. And I think that should deal with
Ah,
it.
yes. And you should
Mm.
add also that this is one of the most things that making your knee more painful, that you are gaining weight. You should decrease your weight because this will cause more pain. This by referring for physiotherapy, and you can refer also for dietitian. You can refer also for dietitian. Okay,
Mhm. Yeah.
to control his weight. Okay, thanks. Please add these two questions in your book. Yeah,
Will
continue.
do. Perfect. Shall we take a break for 5 minutes?
Okay, no problem.
Because no, do people want a break, or I'm happy to carry on. If people don't want a break, I'm happy.
You want to break?
No, no one. And obviously you'll be able to change it and do it yourself. Right? Good.
Dr. Muhammad, we didn't record this station.
Oh, well, you stopped the recording, didn't you? All right. Is
We
it
still,
just this station? Yeah, it's just this station. That's fine. I can
no,
do it. We can do it quickly again. All right.
start again.
Yeah. So for people, sorry, we forgot to record, but this is the second station, which has an angry patient. There is a video in your drive of this station, so please watch it after we finish the lecture. Please watch the video, okay? The story essentially is you're speaking to a wife of a patient who's waiting for a CT scan to happen, but the CT is broke, and you're going to speak to her to apologize and discuss other options, okay? So obviously she's not happy because the CT scan is broke and her husband is waiting for a CT scan, okay? So you go into the station, you introduce yourself, okay? um, and you tell her basically you're sorry that she's been waiting for the consultant. She's going to ask if you're the consultant. You're going to tell her that you're not the consultant and the consultant has been called for an emergency, okay? And then she's going to tell you that she knows that the CT is broke and she wants to know what the options are, okay? And you will apologize. You'll tell her it's a very tough situation, and you'll tell her a bit more about her husband and that he's waiting for a CT scan, but unfortunately, we're currently experiencing problems with our CT machine. Again, she's going to ask about other options or what other investigations can we do or any alternatives. So we tell her why we're requesting the scan, and you'll tell her that the alternatives are basically an ultrasound scan that we can do temporarily, or we can do an MRI scan, but you'll have to speak to your consultant before requesting it. Or if there's any delay that will affect his health, then we can send him to another hospital to do a CT scan. Okay. She's also quite unhappy because there's only one CT scanner and it's a small hospital. So you apologize for that, but you tell her that even though you're a small hospital, you still do all the required investigations within 2 weeks' time, as per the 2-week wait in the NHS. Okay, and if we think that there's going to be a delay, then we will send him to another hospital to have the scan done. Okay, and Dr. Salah said obviously this is a very important question about does he have cancer? So again, answering in a diplomatic way, in order to give a patient the diagnosis of cancer, you should be able to answer questions like a stage, or where's the primary tumor coming from, or whether it has spread or not, or what's the prognosis, or what's the treatment. And obviously we don't have the answer to these questions yet because we're still awaiting investigations and they weren't given to you in the scenario, so you won't be able to answer them. And that's how basically you answer the question to the patient. You'll tell her in a diplomatic way that we don't really have all the information yet. We're still waiting for the scans and the results to come back. Okay.
Wait, يعني now they are asking, can we tell this not cancer? If you have acidic fluid and came for
No, you
you
can't say it's
with
not
this
cancer. We always said don't confirm or deny. So if you say it's not cancer, you're denying, and that's not good, and you lose points. Okay, so if you're not sure, then just say you're not sure and you're waiting for results to come back, and that's the diplomatic way.
but it's written for you that malignant cells, يعني acidic
Yes.
fluid,
So
malignant
most
cells. So you
likely
will
it
tell,
is, but yeah,
you will tell,
yeah,
you
of
will tell
course.
that.
That's what we said. We have a fluid analysis which tells that there is cancer, but we can't answer all the questions yet because we're still waiting for results to come back. Okay,
Okay.
good. And then she's going to ask, will he have surgery, or will he require surgery? Will he need surgery? And of course, again, we don't know all the information yet, but we know that there's ascites, there's malignant fluid, malignant cells in the ascites. So it's usually a poor prognosis, really. But you can't you can't tell her that. All you can tell her is when we do an operation for cancer, we only do it to improve the patient's general condition. Okay. In your husband's case, the presence of tummy fluids gives the impression of an advanced cancer. Okay. And sometimes in cases like these, surgery might not be the best option. So obviously we're still waiting for the CT to come back, and we'll discuss the options once we get a clearer picture. But surgery is not always the best option. Sometimes surgery will put the patient in too much pain, and it's better not to have surgery if it's in a really advanced stage of cancer and the surgery is not going to cure it. Then that would be doing unnecessary surgery. So it's not always the best option. That's what you need to explain to her in your own language. Okay? So, for example, it will be unkind to put the patient in pain with little benefit and little hope of improving. But again, we're still waiting for the CT scan. We don't know the clear picture yet, but most likely surgery is not really going to be beneficial. Okay? Is that all right? Good. She's going to ask about shortness of breath and why he has shortness of breath. And that's obviously because the large amount of fluids in his tummy pushing on his lungs. So we can discuss with Mr. Mann if we can withdraw some of that fluids, for example, do a tap to help with his breathing. And also some of the medications might help clear the fluids. Okay, and that's it. Any further questions? No, thank you. And then summarize. Okay. Dr. Salah, did you want to add something?
Yes. By the way, this station, you have video for it. You have very nice video for it. I think you will follow this video by anyhow. Malik, also you will do practice. Don't worry. You will do more practice, especially in communication and history. You will go very smoothly for the exam. Don't worry. You told about alternative like MRI. You told about alternative.
Yes.
Okay. Okay. Last question here asked in one center regarding. Uh, by the way, I told you before, here wife, she will be the one who will communicate with you. So again, you will start by that you take consent. I don't know يعني how to ask here. Try to find very nice way, and it's written that if you will discuss in any case with relative, you should ask him you have consent for that or not. You are authorized to consent to discuss with you or not. And this is very important point written in the updates. Okay. In this station, she will tell you that his brother has ischemic heart disease and he's working in USA. Okay, he's working in America. Could is this in this stage? Could I call him to see his brother or not? This new
Yeah,
question.
we answered this question before in the last course, I think.
Yes.
Yes. So again, you can again try to be diplomatic. We said that the presence of fluids shows that it's most likely an advanced cancer, but you can't tell her to bring her brother or her relative or whatever back from the USA, because it's not your point or it's not your job to tell them what they can or can't do. But you can tell her that the presence of fluid most likely means it's an advanced stage. It would probably be a good idea to phone your brother, okay, to let him know about the case. And it's up to him if he would like to come here to see the patient. I mean, yeah, that would be my guess. Whenever I get questions like these, obviously I'm not going to tell them to come all the way from Canada or from the US, and then nothing happens, or the patient it becomes well, or the patient dies. So you really don't know. You can just tell them what you know, which is the prognosis is not really good, and it'd probably be a good idea to let them know. But it's up to him if he wants to come down from the USA. But yeah.
Plus, ischemic heart disease, very important word is that she told you that maybe long traveling is dangerous for him. So better also to consult also for traveling or
Yeah.
not to consult your consultant there, because maybe this will make some troubles for him. Okay.
Yeah.
Okay. Thanks.
Okay, I think we've only got two more stations, almost done. So, counseling a patient before stopping warfarin. I believe this patient is blind. He has a recurrent inguinal hernia. He had surgery 30 years ago. Yes, he is blind. The patient has a mechanical heart valve and he's on warfarin. Okay. He's planned for an operation. So, obviously, because he's going to have an operation, most likely for his hernia, we should stop the warfarin and convert to low molecular weight heparin. That's what we usually do. Okay, and then we can restart the warfarin after the procedure and do bridging. Okay, so here the patient is worried because he doesn't want to stop the warfarin. He's worried if he stops the warfarin, he will get some clots, and basically your task is to speak to him. All right. So you go in, introduce yourself. Hello, Mr. John, or whatever. I'm Mo. I'm one of the doctors. I've been told that you're having some concerns about stopping your warfarin. Okay. Can you tell me about your apprehension towards this, or can you tell me what are your reasons, or can you tell me why you're worried about stopping your warfarin? Again, you can say it in many different ways. He will tell you, I was told if I stopped warfarin, I will get clots. Okay, so here you just explain to him what warfarin does and why he's taking it. So first let me explain what warfarin is and how it acts. Warfarin is a medication that thins the blood by preventing the production of certain chemicals. It is prescribed for patients to prevent or treat the formation of blood clots. In your case, you have been prescribed warfarin to prevent the formation of clots over your artificial valve. As we are going to operate upon you, we will have to stop the blood thinning effect of warfarin for the fear that it may cause bleeding during or after the operation. The problem is warfarin has a long duration of action. So to eliminate its action, we have to stop it 5 days before your surgery. But we cannot leave you without protection for this period. So to keep you safe from the formation of blood clots, you will be given another injectable drug, which is called heparin. And that will be equivalent in effect to warfarin. It's very important to tell him that it's equivalent in effect, okay? But has a shorter duration of action, so we can stop it 12 hours before surgery, okay? And again, you can say it in your own way, but this is what you need to tell him basically. You need to tell him that we'll give you another blood thinner instead of the warfarin, which will have the same efficacy, but it will have less risk of bleeding in the operation because we can stop it 12 hours before the surgery. Okay, and again, I'm sure we do this all the time. If you've been working as a doctor anywhere, this is just standard procedure, standard protocol for anyone who's taking warfarin. And we're all surgeons, we've all done this before. Okay, so he will ask again, even though we explained to him, he will ask again if they are both blood thinners, why do I need to stop warfarin? Basically saying if it has the same effect, then why can't I just continue taking the warfarin? And again, even though you explained, you'll explain to him again. So both of them are providing the same blood thinning effect, okay, that will protect you from the formation of blood clots over your artificial valve. But the difference is warfarin has a long duration of action, which means it will be acting up to 5 days of its stoppage, while the other medication or the injectable heparin is only 12 hours of action. So it can be stopped shortly before your surgery. Okay. So he will ask, will I still have to take these injections after surgery? Okay. So after your surgery, and if we're satisfied that there's no more bleeding, we will continue giving the injectable heparin together with your warfarin till we get sure, or we make sure that your blood investigations are within range, or that your blood thinning effect of warfarin is regained, which is INR basically, okay? And then we will stop the injectable heparin. So really standard. Guys, after the procedure, you restart the warfarin, but you continue taking the injections until the INR is within range, and then you stop the injections, okay? So simple stuff. And that's usually done by the anticoagulation nurses. You don't have to worry about it. Anticoagulation nurses. There's also anticoagulation clinic, which is done as an outpatient. So all of this can be done without you bothering, but you have to explain it to the patient, okay? The patient will tell you, will I need to stay in the hospital? Well, I need to stay in the hospital before surgery while taking the injection. And this is really a difficult, I wouldn't say a difficult question, but it's caused some controversy. We never keep patients in to take injectable heparin, okay? They can take it at home, but the difference is this patient is blind, okay? And he might have some hearing difficulties as well. So he might struggle to inject himself. But normally, every other patient, they inject themselves with heparin because it's a one-use needle, okay? For example, Clexane or enoxaparin or deltaparin, they sell it as one-use needles, okay? And the patient puts it in his tummy, he presses, he clicks. It's like an insulin needle where patients inject themselves with insulin. So it's really straightforward. All the patients do it to themselves at home. So he doesn't really need to stay in the hospital. But because he's blind, he may need to stay in the hospital if he can't inject himself, okay? Another
Uh,
alternative be to, sorry,
you can escape also from this question that we will discuss with social worker to
yeah,
arrange a
exactly.
nurse. Yes, by this way.
Yeah, so the other option would be a district nurse, which is what we usually do because really we have limited hospital beds in the UK. You can't keep a patient in because they're taking heparin or taking Clexane. That's just taking up valuable hospital beds, and it costs a lot of money to keep a patient in the hospital. So a cheaper and a better option would be to send the patient home and organize the district nurse or the community nurse to come in once a day to give him an injection. And that's something that we do normally for a lot of patients, for example, very frail patients or elderly patients or patients with dementia or whatever. They can organize the district nurse or the community nurse to come in and give the patient an injection once a day at home. So you can also say that, okay? So instead of this answer, we can say um, you don't normally need to stay in the hospital to take your injections. Most of the patients are able to manage it by themselves at home. You may need to see the anticoagulation nurses or go to the anticoagulation clinic to make sure that your blood tests are within range, okay? Because we need to make sure that the INR has gone down. And if you're unable to inject yourself, we can organize for the community nurse to come in and give you the injection once a day if needs be. And if that all fails, if we can't organize that, then unfortunately, you may need to stay in the hospital during those 5 days if we're unable to organize this. Okay. And I think that would be a good way of answering it. So you're giving him all the options. Okay. Because what usually happens here in the UK for elective, this is a hernia, most likely. So it's an elective procedure. Okay. So what they do is they give the patient some leaflets. Okay. And they go to the outpatient department where there is an anticoagulation clinic, and it's run by specialist nurses. They're anticoagulation nurses. They take the INR, they measure everything, they give the patient the Clexane or whatever, and they bring him back maybe a day or two before the surgery just to make sure that everything is fine, and then they can go ahead. And even after the procedure, the patient is discharged and he goes to see the anticoagulation team as an outpatient department so they can stop his Clexane once his INR is within range. So it's all managed really as an outpatient. There's
Your
no
voice.
need, yeah, no need to keep him in the hospital. But yeah, okay. Um, you should not. Yeah, his patient is asking about diazepam. He's asking, I take diazepam for anxiety. Um, and he's asking, do I need to take it or can I take it on the day of your surgeries? And of course, diazepam is absolutely fine. But again, we should let the anesthetist know because it is a benzodiazepam. But if he takes it for anxiety, then it's better not to stop it so he won't be anxious. And we'll let the anesthetist know. And obviously, he should just have it with a small sip of water. Okay, good. So you can take it up to the morning of the surgery. Um, you ask the patient, do you have any further questions? And the patient here will tell you no. So again, thank you, and then summarize, and that's it. All right. But Dr. Salah, do you have any additions to here?
Yes, yes.
Yeah.
This station is very important as the patient is blind. How to communicate with patient, blind patient, how to communicate with him. This is the difference. You have no body language here. How he will know that you are a doctor and you are with him in the same office now to discuss? You should um, greeting him and put your hand over his shoulder. Okay, to know that you are coming now. This is the only station you can put your hand over his shoulder. Okay, because some people they told me if I will so especially anxious mother or crying mothers. She's angry. Can I make her calm by putting my hand over her shoulder or not? That's not allowed. يعني بالعربي. يعني يا شباب لما تلاقوا الانشيوس ماذر او شيز كراينج ما ينفعش تطبطب عليها. البلايند بس ده اللي تطبطب عليه تعرفوا انك وصلت يعني. بالمناسبه واحد I will tell very nice story about our candidate. He told I did very bad in this station in anxious mother. So I put my hand over her shoulder when she's crying. And this is not good point by the way. Not good point by the way. فبساله بقول له انت عملت كده ليه؟ قال لي ما حلتش كويس ودافع فلوس اطبطب عليها بقى يبقى ولا نجاح ولا طبطبه. Okay, so please don't touch patient except the blind one. يعني this accept. I don't know in COVID is this will be allowed or not, but I think يعني this not big issue when you will put your hand over his shoulder to know that you are the doctor and the team.
I think during the pandemic you shouldn't because we don't shake hands with the patient, so unnecessary contact shouldn't be done. Obviously if there's an examination then you'll have to examine the patient, but you'll be wearing an apron, you'll be wearing gloves, you'll be wearing masks. But even now, because before the pandemic we used to shake hands with the patient. Whenever you see a patient you shake his hand and well, obviously introduce yourself, shake his hand. But now we're not allowed to shake hands with the patients, so I don't think I'm not sure obviously what's going to happen, but I don't think it would be a good idea to make unnecessary contact. But again, the what might happen in the exam
ماشي
is
انت بتتكلم على تشيك هاندز. انت بتتكلم على
yeah it's contact in
بتتكلم على
general.
تشيك هاندز بيسلم.
Okay.
انما مش تطبطب، مش تروح تطبطب يعني، لا لا. Yes contact يعني I think for blind patient I think for يا عم كان بيطبطب ويعني كان بيقول لك بفلوسي بقى. المهم I think in this patient I think you will not do that. Even in blind patient you should let him aware that you are in the room with him and he can't see you. This is why before we are doing that. I think nowadays this will not be allowed. Okay, yeah.
Good. So I'm not going to do the Jehovah's Witness station. I don't think it has come really in ages, and it's not common in Cairo or any of the Arabic centers. But I've written all the answers and questions if you guys want to read it. Obviously, people who are Jehovah's Witnesses, they refuse blood transfusion, and basically that's the essence of this consultation and speaking to the patient about it. All right. Colonoscopy
Just for reading. Is this just for reading?
Just for reading. Colonoscopy is
this
the
and
same.
colonoscopy just for reading.
Just for reading.
Yes.
And the total knee replacement station. This is a new station. Well, fairly new. I think the first time it was introduced was last year. I think. It's not that common yet. Do you know, Dr. Salah, if it has come up in Cairo exams or in Bahrain
No,
or
no.
Oman?
Is this
Only
station
in
for
Sheffield,
the
I
first time?
think.
Yes, came in Sheffield for the first time
Yeah.
in day 1 and day 3. And
Yeah.
I think Sheffield they have many days for the exam, or London they have many days. And the one who gave me this station, I am trusting him. She told me frankly, they have a station about TKR, total knee replacement. What is the details of this station? She doesn't know. She told me nobody told me about anything. So this station came for the first time in Sheffield and not coming after that at all. So please wait this station in any center. If they will start to bring it once, so wait this station anytime. By the way, Dr. Muhammad, when this station came, I asked Dr. Muhammad, please, I want some communication skills about TKR from NHS UK only. So he sent the very nice paper about 39 pages. I remember 39 pages about this. Then we discussed together to collect these questions. So this is not the question and this is not the station. Only to be familiar with the station if we come for you for the first time, how to answer, how to reply. This only from us, not from the station itself.
Yeah.
Okay? Because we
Exactly.
haven't any details.
So unfortunately, because this is a new station, we don't have really much detail or any detail at all. All we know is it's a consultation about a total knee replacement. So I've worked in a few hospitals here in the UK, and obviously a total knee replacement is a common procedure, and I work in orthopedics. And for patients who are going for an elective knee replacement, we give them a leaflet, and this leaflet has the most common questions and answers. Basically the most common questions that the patient may ask about their procedure. So it's a leaflet, maybe 10, 20 pages. In other hospitals, it might be a bit bigger, like 30, 40 pages about the details of the operation in simple language, explaining to the patient everything. So I've just had a look at a few of these leaflets, and I basically took down a few questions and I've added it to a station. So we can read it together, but we don't really know if this station will appear again or not, but it's a good idea to read it. It's a really simple station, okay? So again, you go in, you introduce yourself to the patient. I'm Mo. I'm Mo. I'm one of the surgical doctors, or I'm one of the orthopedic SHOs. I've been asked to talk to you about your knee operation, okay? Is there anything specific you would like to know? So instead of talking about a knee operation, you can talk for hours about a knee operation. You need to ask the patient, what do you want to know exactly? Because you can't just keep talking on forever, okay? So he will tell you, how long does the operation take? And a knee replacement usually takes somewhere between 60 to 120 minutes. Let's stay on the safer side, let's say around a couple of hours. But of course, there will be an aesthetic time beforehand, there will be recovery time afterwards. Okay, so a few hours in total. Okay, are there any complications? Okay, and obviously any procedure has risks and complications. So you tell him no surgical procedure is without risks. Okay, and then you can list some of the risks. Okay, some of the complications include, for example, bleeding or stiffness or pain or damage to the nerves and vessels or clicking and clunking, risk of infection. You can just list them, okay, and then you can ask them, is there anything in particular you want to know, or is there any risk in particular that you're worried about, or is there anything in particular that you're worried about? And then you can explain it in a bit more detail. For example, if he tells you, I'm worried about bleeding, so you can tell him it's common to have a small amount of bleeding from the wound after surgery. It's usually no major issue. Okay, we'll make sure to give you the proper medication to reduce the risk of bleeding, and we'll make sure that the wound is closed nicely to reduce the risk of bleeding. Okay, he might be concerned about pain. You will tell him the operation is designed to remove arthritic pain, but you will have some surgical pain afterwards, which we can get on top of with painkillers, or we can give you some strong painkillers after the procedure to make sure you're not in pain and you're comfortable. Okay, he might say, I'm concerned about infection. You will tell him, we'll do the operation in sterile theaters. We use clean instruments to reduce the risk of infection. We'll give you antibiotics before we put you to sleep to reduce the risk of infection, and so on. Okay, concerned about blood clots, you can tell him we'll give you blood thinners after your operation to reduce the risk of blood clots. We'll make sure that you're mobile and well hydrated to reduce the risk of blood clots, and so on. And he even might ask about it. So here, what methods will be taken to prevent blood clots? You can tell him most important factor is keeping well hydrated and mobile. Okay, more important that you walk, exercise, and again, we might give him some stockings, for example. Some hospitals here, they give TEDs to patients after the operation. It's not really common, and I think most hospitals now have stopped doing that. Okay, but we give aspirin, and according to nice guidelines, we give aspirin for 2 weeks after a knee replacement. Okay. Can I have breakfast on the morning of the surgery? Of course, he cannot. Please do not eat anything at least 6 hours before your procedure. Okay. Will I be put to sleep? Again, it's not your place to say. This is a discussion that the patient will have with the anesthetist. So there is an option of a spinal, anesthetic, or a general anesthetic, and it's usually a discussion that the anesthetist makes with the patient. Some patients do not want a spinal because they don't want to be awake, or they are afraid of having a spinal. In that case, you can give them a GA, or sometimes you can explain to them that we can still give you a spinal with sedation so that they're asleep. And again, that's a discussion that they will have with the anesthetist. Okay. How long will I need to stay in the hospital after surgery? Of course, this is different from one patient to another. Okay. And there are a few things that we need to make sure of before the patient can go home. He must be able to walk safely. He must be able to use the stairs, especially if he has stairs at home. His wound has to be well clean, with no oozing or signs of infection. Blood tests have to be fine, and X-ray has to be satisfactory. Pain has to be under control. He has to be medically fit, and he must be able to bend his knee. And if all these happen, then he can go home. And it usually takes a few days. But of course, it differs from one patient to another. Some patients go home day one. I've seen this a lot. And some patients go home maybe day 5, day 6. And it differs, of course, on the general condition of the patient. It differs on their situation at home, and if they have stairs at home or not, and everything. Okay. So the safe answer would be a few days, but we need to make sure that your blood tests are fine, your x-ray are fine, your pain is under control, your wound is fine, you're able to walk, so on. Okay. In terms of follow-up, when I'll need a follow-up. So in the UK, it's generally 6 weeks and 6 months after a knee replacement for the outpatient department with the surgeon. So 6 weeks after surgery. But the patient goes to his GP, or the district nurse sees him in 2 weeks to remove the sutures or remove the clips, and to make sure no signs of infection. Okay. And usually use clips for knee operations. So you remove the clips in 2 weeks, and that's done by the GP or the district nurse, but then he sees the consultant at 6 weeks. When can I return to work? Obviously, it will depend on what the patient does. So if he asks you that question, you will tell him, what do you do for a living? What do you do for a living? And of course, it's different. If someone is in, for example, doing an office job, is different from a postman, and different from a warehouse worker, or someone who does a lot of physical work. So it's really different. But again, at least 2 weeks, at least, until the wound heals and the sutures come out, and then it will depend on what they do for a living. And so you can answer the diplomatic answer, which it depends largely on what you do for a living. Okay. How soon will I be able to walk? Of course, after the knee operation, you can walk on the first day, okay? But we need to make sure that the physios see him and the pain is under control, okay? Will I be able to go swimming? Yes, he can go swimming, but after the wound is healed, so at least 2 weeks for the wound to heal, and then he can go swimming, but you need to warn him that he needs to be careful and confident using his knee. He doesn't have any pain, and that he can manage the wet pool side, because of course, there is an increased risk of him slipping if he is not in control of his knee, and he can slip and fall and cause a fracture or cause an injury. So he needs to be able to manage the wet side of the pool. He doesn't have any pain, and his wound is healed. So normally I would normally say for them probably 6 weeks, but again, everyone's different, but it depends. Okay. When can I start driving? Again, minimum of 6 weeks. Make sure that you're confident to do so. Make sure that you're able to pull an emergency brake. This is important because basically driving is a contract between him and the DVSA. So he needs to make sure that he is safe and he's confident pulling an emergency brake. Okay. And another thing is, you can tell him to speak to the insurance. It would be a good idea to speak to your insurance company, because here in the UK, you're not allowed to drive without an insurance. And sometimes if you had surgery, then the insurance company won't insure you. So he needs to let the insurance company know. Okay. How soon can I travel? Because there's an increased risk of blood clots, it's usually recommended to wait 3 months before flying. Okay. Because there's an increased risk of blood clots forming in the leg. But for any other long distance travel, such as train or car or bus, then make sure that he takes regular breaks, and he stops often to walk and basically move to prevent the blood clots from forming in his legs. Okay, and that's it. Ask him if he has any further questions, some advice and safety netting. If any of you have this station, please let us know what the questions are, and we'll add them to the book for future courses. But hopefully, those are the most common questions that you will get if this station were to be in your exam. That's it. Thank you. Dr. Salah, have you got anything to add?
Thank you, Muhammad. No, I think you finished from everything. Today is amazing. They should do practice only. After reading that, they should do practice only for communication.
Yes, so it's communication and history is practice, 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 really. That's the important thing, and that's how you'll pass your exam. You have to have someone with you to practice with. If you don't have a colleague that's taking the exam, then you can practice with a family member, with a friend, even a non-medical friend. You need to practice with someone. You can practice with your brother, with your sister, your younger brother, your mom, your dad, a friend, anyone really, or even some people from the course. If you do a Zoom meeting and you practice together, because this is the important bit. And also time yourself. So use a timer when you practice, so you get a good idea of time management. So set a timer and start practicing and see if you can finish all the questions within 9 minutes. And it takes practice, and that's all you need for communication, really. Good.
Okay, they are asking when we will do mock for that. Already we'll do many discussion. We'll do many discussion for communication and history. I will start, by the way. Today we are waiting the Royal College meeting. After that, we'll decide when we'll do practice. So you have many practice for communication and history. And if no exam will come, I will do practice with you on every week. And I decided with Dr. Shinoda, after finishing of the course, you will find the Thursday and the Friday at 11. You will have discussion with me, okay? Without waiting the exam, to be on track only. This will be happened, inshallah, after finishing of the procedure. You will have Thursday, Friday at 11 p.m. if no exam is coming. But if you have exam is coming, decided, scheduled, so you will have your practice with us. Okay? So next Wednesday and Monday. So coming Wednesday after 2 days, this will be procedure 1, it will be live. And Monday, it will be another discussion for last procedure. Then we will put plan for, I will give you 1 week rest, then we'll practice for history communication. I will start with you with the skills. All skills will do mini practice for them. ماشي يا شباب.
Good.
بالتوفيق إن شاء الله.
Any other questions? No. All right. If there are any questions, feel free to write them on the Telegram group. All right. Thank you very much. Thank you, Dr. Salam.
شكرا دكتور محمد. يلا مع السلامة. اشوفكم على خير يا شباب.